So I'm going to talk today about the hemodynamic assessment of aortic stenosis. I will start with some basic slides, then it will get more advanced progressively. This is a simultaneous left ventricular aortic pressure recording in a patient with severe aortic stenosis. So I want to highlight the morphology here. So always in hemodynamics, don't just look at the numbers, always look at the morphology. So when there is a pressure difference in systole between the LV and the aorta, a hallmark of aortic stenosis. But regarding the morphology, the aortic upstroke in severe aortic stenosis is not parallel to the LV upstroke. No, notice how it is delayed and it peaks late. The aortic pressure peaks late. So it's a slow upstroke with late peaking of the aortic pressure. Basically, that aortic upstroke starts normally initially up until the valve hits the opening limit. Let's say it hits 0.8 centimeters square. And after it hits that point, then the flow across it becomes very sluggish and hence the delayed upstroke. That point where the aortic pressure hits the limiting point, it's called the anacrotic notch. So that point where the aortic pressure bends is called the anacrotic notch. I want to also highlight a couple of important ideas on this tracing. There are three types of pressure gradients. You have, and you need to know those very, very well. We use that terminology all the time. So you have what we call peak instantaneous gradient, which we also get by echo Doppler. It's the highest instantaneous point-to-point gradient, which corresponds here to the green line. The second type of gradient, and the most important type of gradient, is the mean gradient, which is the integral of the area under the curve. That gray area, it's the integral of that, of every point-to-point instantaneous gradient. And that's the mean gradient. And the third gradient that we only get by cath is what you see in red. It's the peak-to-peak gradient. Okay, it's not a physiologic gradient. It's basically the difference between the highest points of the LV and the aorta. So you need to know the relationship between those three types of gradients. If you go by echo, you remember, you should know that we call it severe AS when the peak instantaneous gradient is over 64 or the mean gradient is over 40. So that gives you an idea. In general, the mean gradient is about 2/3 to 70% of the peak instantaneous gradient. You need to know that relationship. Now, how about the third one, the peak-to-peak gradient, which happens to be the gradient we like the most in the cath lab because that's the one our eyes can grasp the fastest. So the peak-to-peak gradient almost approximates the mean gradient. Okay. So again, the peak-to-peak gradient is almost about 65% of the peak instantaneous gradient. Okay. That's, they are not always equal. Actually, in my experience, more often than not, the peak-to-peak is a little smaller than the mean gradient, contrary to what one may think. The more severe the AS, the larger that area under the curve, but that aortic pressure doesn't decline as much as the area under the curve increases. So peak-to-peak almost equal. Sometimes it's a little less to the mean, and definitely about 2/3 of the peak instantaneous gradient. Okay. So those are general ideas. Most important thing to remember, slow upstroke of the aortic pressure with anacrotic notch. Another two terms we use are that slow upstroke and late peaking of the aorta is what we call pulsus tardus on carotid exam. And that reduced pulse pressure of the aorta, we call it pulsus parvus. Those are two terms that you use often. Okay. Notice though that there are some things that may alter that morphology, particularly age. Older patients with non-compliant stiff arteries may have a sharper upstroke and less anacrotic notch. And they may have a more pronounced pulse pressure. So the pulses tardus and parvus become less sensitive in the elderly, and the anacrotic notch may get attenuated. Okay. Notice also in general in aortic stenosis, not only there is anacrotic notch, the dicrotic notch tends to be attenuated, evidently because the valve barely opens, so it will barely closes as well. There isn't a lot of movement upon its closure. So this is another tracing that I like. This is another, and I show this all the time, this is another LV aortic pressure recording. And you can see here, you know, your eyes should catch. So it seems like there is a big gradient. You would think it's severe AS, but that's the importance of analyzing the morphology. The aortic upstroke is parallel to the LV upstroke. Therefore, this is not aortic stenosis. What this is what we call error in zeroing. Basically, the two transducers are zeroed at two different levels, which creates a fake gradient. And I will go over that a little later. Okay. And I'm going to highlight another important differential diagnosis of a high LV aortic pressure. So this is one differential diagnosis, which is false measurement, error in zeroing. Second and most important differential diagnosis of an LV aortic pressure gradient is what we call HOCM, dynamic LVOT obstruction. And here the morphology is what helps makes the differential. So notice the aortic stenosis morphology here on the right side, and notice the HOCM morphology on the left side. So in HOCM, the LVOT obstruction is dynamic, meaning it gets worse in mid to late systole. The more the left ventricular contracts and empties, the smaller the LV cavity becomes in systole, the worse the LVOT obstruction becomes. So basically, you start with no obstruction. As the LV starts to eject in systole, there is no obstruction, and the LV and aorta are hugging each other. Somewhere in mid-systole, you start having LVOT obstruction, and at this point, the aortic pressure dramatically drops, and whereas the LV pressure sharply rises, and you have a sharp late peaking LV gradient. So LV rises sharply at the end, aorta drops at the end of systole. And this is what is called spike and dome morphology of that aortic pressure, and what we call late peaking dagger-shaped LV pressure and LV aorta gradient. Okay, so if you look at it, it looks like a knife, and I'll show you another picture of it. So, but contrast this with that slow upstroke, whereas this one, very good early upstroke, late gradient in HOCM. Okay. In HOCM, we generally go with peak-to-peak gradient. We use mainly the peak-to-peak and the peak instantaneous gradient. We do not use the mean gradient in HOCM. So this is another illustration of HOCM. So you can see here, we are pulling. So we have a catheter in the LV, and we're pulling it back all the way in the aorta. So this is the catheter in the LV body. We're pulling it back in the LVOT, and you notice the dramatic drop in pressure. Importantly, you change in morphology. So the pressure in the LV, it's this one. The pressure in the LV body has that late peaking dagger shape. So it looks like a knife. Imagine it. It's exactly like a knife. Remember that morphology. So it has that knife morphology. Then when you pull in the LVOT, not just in the aorta, in the LVOT, you get and embrace that spike and dome morphology. So you get that spike and dome morphology in the LVOT. Then you pull back in the aorta. There is not much of a gradient between the LVOT and the aorta. The gradient is mainly between LV body and LVOT. Okay. Any questions so far before I move to more technical aspects? All right. So I'm going to describe how to obtain those simultaneous recording between LV and aorta. or how to obtain gradients in general. So there are three major techniques. The first one is what we often do, which is called pullback technique. Basically, we only use one catheter and we pull it back from the LV all the way to the aorta. So this is what we do routinely. I want you to know that this technique is not simultaneous and therefore is really not accurate to assess, is not accurate to assess suspicious cases of AS. It's only useful in extreme cases. Is useful in cases of unsuspected AS, where your gradient comes up, your peak-to-peak pullback gradient comes up less than 10 to 15 millimeter of mercury. In this case, you rule out severe AS. And it is also useful when the gradient is very high, over 40 millimeter of mercury. It is not useful whenever your peak-to-peak gradient is somewhere between 15 to 40. It's not useful to assess aortic stenosis. And that happens to be the case of most aortic stenosis we like to assess invasively. So it's really essentially useful to rule out aortic stenosis. It's not useful to make accurate measurement. And when we do pull back, you have to, the reason it's not that good is that you have to try to superimpose the same respiratory cycle upon pullback. You know, the peak inspiratory beat with the peak inspiratory LV beat. It's very tricky if you have, of course, atrial fibrillation. It's even more worthless in atrial fibrillation. This patient, interestingly, has severe gradient. Interestingly, you know, the morphology, though, of the aorta, of the aortic pressure, it doesn't look like severe aortic stenosis. Now that's, you know, a 90 years old patient. And that goes to my point that sometimes the very elderly may not have that perfect morphology. You may not have a good anacrotic notch in the elderly. That's an extreme case. You should still have some anacrotic notch and some degree of pulsus tardus. But that's an extreme case in a patient with very stiff artery, non-compliant arteries. So that's the first technique of LV aortic pressure measurement. Again, it's not useful in real AS cases. The second technique is to do simultaneous recording using a sheath, and a catheter in the left ventricle. So you put a big sheath in the femoral artery and a smaller catheter inside it that goes in the left ventricle. So much so that you measure the left ventricular pressure through that catheter, and you have enough space between the catheter and the sheath to measure the femoral pressure, okay, or the aortic pressure. For example, you put a 6 French sheath in the femoral artery, and you put a 4 French sheath in the left ventricle, okay? So there is a catch of putting that sheath in the femoral artery. In this case, you just do simultaneous left ventricle, femoral arterial pressure, assuming the femoral arterial pressure is equal to the aortic pressure. There is a problem that's not always true. The femoral artery is often amplified compared to the aortic pressure. There is what we call this phenomenon of peripheral systolic amplification, okay? This is actually more likely to be seen in the case of high flow state, severe aortic insufficiency, and in young patients. The younger and healthier you are, the more, the higher your peripheral pressure is compared to the aortic pressure. That's why the normal ABI in young people is about 1.1. Okay, so therefore, if you're assessing for aortic stenosis, using the femoral artery may underestimate the true gradient. Also, the femoral artery is more delayed compared to the aortic pressure. So it's not ideal to use a femoral sheath and LV pressure. So part of the second technique, the best way is to put not a small femoral sheath, is to put a long sheath, something like a 65 centimeter sheath, 6 French or 7 French, all the way to the descending aorta, and through it put a 4 French sheath into the left ventricle, such as a 4 French pigtail catheter. Okay, and this is the most common technique nowadays of doing LV aortic simultaneous measurement. Okay, and also part of the second technique, if you want to use the radial axis instead of femoral axis, what you can do is it's tricky. You cannot use a standard 65 centimeter 6 French sheath through the radial artery. You will get a lot of spasm, and worse, you may be able to get it in, but you'll have very hard time taking that sheath out. It's very tricky, definitely not in women, and even in men with large arteries, it will be a problem. So the only way of doing it radially, and it is available nowadays, is to use what you call the slender sheath, long slender sheath. It's the same type of sheath that's used for radial to periphery interventions. It's available in 75 centimeter. One, it's a slick hydrophilic sheath. Two, the outer diameter of that 6 French slender sheath is equal to a 5 French sheath, the outer diameter. So we use a 6 French 75 centimeter slender sheath all the way to the aortic arch, and through it we put a 4 French LV catheter. Okay, so that's how we do it in the radial era. So those are the first big technique. One, the pullback, which is not good. Two is the simultaneous sheath LV pressure. Try to avoid femoral sheath or standalone radial sheath. Try to get long sheath and make them land in the aorta. Now, the third technique is the Langston catheter, which has currently been removed from the market, but I expect it to eventually be available in the future. So it's a catheter that has 2 lumens. It's a 6 French. It's available in 6 or 7 French catheter. And it's like you have 2 parallel lumens inside it. One of the lumens end in the aorta. Another lumen ends more distally in the left ventricle. Okay, it's almost like you have 2-3 French lumens in one catheter. Okay, one problem with that catheter is that the 2 lumens are fairly small, and sometimes you can get damping, especially of the aortic pressure. It can be very damped, which can lead to overestimation of gradients. Okay. And this slide here for you to read, it kind of summarizes the 3 techniques I described. Okay. So again, the pullback is mainly used to exclude AS when your pullback gradient, peak to peak pullback gradient, is less than 10 to 15 millimeter of mercury. Any questions so far? All right. I will give more technical tips. Before I go further, I'll show you this simultaneous LV-aortic pressure recording in a patient with severe aortic stenosis. So again, in the cath lab, we like peak-to-peak gradient, which is the easiest for us to grasp. So we look at this peak and this peak. And here, every interval is a 20 millimeter of mercury, according to this scale. So this patient has a peak-to-peak gradient of approximately 40 millimeter of mercury, which puts you in the severe category. Okay. Notice the morphology. Notice that anacrotic notch and late peaking of the aortic pressure. There's a little delay because the tubing on one transducer is longer than the other, so which creates a non-physiologic delay of that aortic pressure. It's very important, even when you're doing simultaneous pressure, to do and record the pullback pressures, okay? So we pull back, and when you pull back, evidently your pressure should be equal across both transducers. The aortic pressure should be the same across both transducers. And that pullback maneuver is very important because it unveils whether you've been having problems in your recording. Let's say you pull back and the 2 aortic pressures are not superimposed, then you know you had an error in zeroing. Basically, the 0 level of both transducer was not correct, or you had an error in damping. Those are the 2 big errors that can occur, and I will explain those. Okay. In this case, the 2 pressures were almost superimposed, which retrospectively confirms that our recordings were accurate. Okay. So here's the thing. So there are 3 types of recording errors, and I will explain how to avoid those and how to record those. One is error in zeroing. The 2 is error in damping, and the 3 is error in positioning. I'll explain each one. So first, error in zeroing. So imagine this is LV and aortic catheters, and each one is connected to a transducer, okay? Imagine that this transducer one, which is connected to the left ventricular catheter, imagine you zero it. And the way you zero those transducer, there are stopcocks in the system. You open this stopcock and that stopcock to air, and you place those stopcocks open to air at the same level, whether you open them here or you open them there. You place them at the same level, and you zero both recording at that level. Imagine you place that open transducer 5 centimeters higher, the black one 5 centimeters higher. If your zero level 5 centimeters higher, then inherently the recording of the transducer one, the pressure recording of transducer one, will be 5 centimeters of water less. So inherently your pressure measurements will be inaccurate. So you need to zero at the same level to avoid that this fake discrepancy in pressure correspondence. Okay, that's an easy error to correct, error in zeroing. The second error, and the more difficult to correct, is this one, the error in damping. I will just explain here what does damping mean. And here I'm talking damping in general, not damping when you engage a coronary artery. General damping in catheter recordings. So this is an aortic pressure. It has a nice upstroke and it has a nice dicrotic notch. This is a normal, what we call normally damped LV pressure. It has dip in diastole, it has A wave, it has a dip in systole. Those are normal recording through column fluid, through catheter-filled fluid transmission into catheter filled with fluid. Okay, that's the normal damping. This is an overdamped, or what we call damped aortic pressure and damped LV pressure. So notice you have no dicrotic notch. The whole pressure is squashed down. So imagine as if you're grabbing the ends of this pressure and you're elongating it. Okay, you pull it outward. So it's squashed down and it loses all its dips and peaks and valleys. That's a damped recording. That's a damped LV, very smooth. No LV dip here, no dips here. So it's extra smooth recording, okay? Conversely, there is another error, maybe not relevant for this talk, but it's called underdamping, where you have too many notches on that tracing. Okay, unlike too smooth, too many notches. You want it to be perfectly damped, which is this. This is, imagine that you have LV and aortic recording. Imagine the aortic pressure is damped in this patient. So look what happens when it's damped. You will exaggerate the gradient. You can create fake, false aortic stenosis or falsely severe aortic stenosis. So you have to be perfectly damped. So you understand the error in the recording. And why does damping happen? What causes damping? So again, let's imagine the aortic pressure, okay, the blue one. Damping occurs anywhere along the way of that. It can occur along the catheter, or along the tubing, or along the transducer. Those are the three levels wherein you can have damping, okay? And what causes damping? I mean, damping, normally you want to have perfect amount of fluid in each of those lines. And you need to have the shortest amount of lines and stopcocks in your system. So damping can occur if instead of saline, you have a blood or contrast or air in your system. That will damp your recording. If your tubing is too long, especially if it is a soft compliant tubing, that will attenuate pressure transmission. Or if actually the catheter is too small. So sometimes if you have, let's say you have 5 French sheath here into, and inside it you put a 4 French catheter, you may have too little space to transmit pressure and your pressure will be damped. So too small of a catheter can damp your recording, okay? So those are the various reasons to have damping. Now we'll go over how to uncover errors in damping, okay? So one, this is a very important thing because in today's era, the only cases we assess in the cath lab for severe aortic stenosis are those cases that by echo have a gradient of, generally speaking, 20 to 30 millimeter of mercury. So very, very relatively moderate gradient, and you're trying to unveil whether they have low gradient severe AS. So really any few millimeter of mercury error in measurement will translate into big error in measurement of your aortic valve area and your assessment of aortic stenosis. So you really need to obtain perfect measurements. That's why you should not have error in zeroing, and your damping should be somewhat perfect. Okay. So 3 levels, damping can occur at 3 levels, and it will be unveiled and corrected by several ways. So one, whenever you see a tracing like this, the first reaction for you should be immediately to flush your system very well, okay? And to try to reduce the length of the tubing. Those are the easiest thing you do. Reduce the length of the tubing, reduce the number of stopcocks, okay? And flush the system well. That's the first thing to do on both transducers. Now, let's say you did that and the pressure is still looking like this. Here you have 2 tips to show you whether the tracing is acceptable or not. You swap both transducer. Normally, so the LV you connect it to transducer 2, and the aorta you connect it to transducer 1. Normally, when you swap transducer, you should obtain the exact same recording. But if one transducer and one line, so let's say we swap those 2 at this level. Okay, we connect this here and the black one to the blue one. So if you have a problem in the damping of the tubing or of the transducer itself, when you swap the transducer, the reverse damping will occur. So now when you swap the transducers and the lines, the LV will be damped, whereas the aorta will not be. So you will have the reverse. So here you have excessive gradient. Now you have attenuated gradient. None of those 2 is correct. The gradient is somewhere in between. So swapping the transducer will unveil error in damping beyond the point of connection to the tubing and the transducer. Okay, beyond the point where you swap, basically. Okay. So if that happens, you need to make a change. You either flush the system again, you change your transducer, you shorten your tubing or change your tubing. Okay. Now, let's say we swap the transducer and we get the same recording. Well, that could be a good thing. That could tell you that, okay, maybe I'm not that damped, even though it looks damped to me. Maybe it's damped because of aortic stenosis. Okay, so you swap the transducer, nothing changes. It could be reassuring. Or it could be that the damping is occurring at the level of the aorta itself. So at the level of the catheter. The damping is in the catheter before the point of swapping. In this case, the swapping will not change the damping. So 2 important tips. Again, 1, you swap the transducer. If you see an error, that's great. You need to correct it. If you don't see an error, you're reassured, but you're not perfectly reassured, especially if the morphology is looking like this, too smooth. So here is the second tip that will unveil an error. And that's why it's always important to do that technique and pay attention to what happens when you pull back in the aorta. As I mentioned, normally when you pull back in the aorta, the pressure recording should be absolutely superimposed. Here, when you pull back in the aorta, if your damping is not horrible, if you're damped but not horribly so, you'll get pressures almost superimposed, and there may be 2-3 millimeter of mercury difference that you can account for, and you may accept your recordings. Conversely, if you pull back in the aorta and there is this massive difference in between the 2 recordings, of the 2 transducers, then you've had a serious problem here across the catheter. At this point, you can tell, since you swapped and no issue, the problems across the catheter recording, then it's a problem. And that tells you that, okay, all I did was incorrect. I need to redo my recording using another strategy. So if what you did was putting a 6 French catheter in the aorta and 4 French in the LV, well, you need to do something different since you were damped and you couldn't correct that damping in the catheter. So one thing you can do is put a 7 French long catheter in the aorta with a 4 French in the LV. Or if it was the LV pressure that was damped, then you can put 7 French in the aorta and 5 French in the LV. So you create more space, larger catheter, more space in the catheter. The ultimate technique in that case is to do double access. For example, radial access to put a catheter in the left ventricle and femoral access to put a catheter in the aorta and use, for example, 5, 6 French sheath on each axis. That's the ultimate technique of simultaneous recording. 6 French access, 6 French double access. We don't often do it, but you may do it in a case such as this. So did everybody understand the errors in recording and how to recognize them first and how to correct for them? Okay. So it's very important to recognize those in our era. Did everybody understand that? I'll show some examples of cases I've had where such errors were made. So this is another case. This is the case I've done. So you can see LV aortic pressure. Again, it strikes that aortic pressure is too smooth. Okay, no dips, no dicrotic notch, no anacrotic notch. So it's too smooth. It's clearly damp. So here it was easy. We flush our system, shorten the tubing, shorten the number of stopcocks, and it's a very different pressure recording. Okay. So that AS in retrospect, was not considered severe by morphology, at least. And I think even eventually the pressure measurement did not come up as severe. So dramatic difference in pressure gradient between this and that. And this is due to damping errors. This is a case I've done actually recently here at the VA. This is a patient whose echo shows a gradient of 25 millimeter of mercury, mean gradient of 25 millimeter of mercury, and aortic valve area of 0.9. Again, this is the most common case that gets referred to us in the cath lab. So we did invasive measurements and simultaneous LV aorta using that technique of femoral sheath in the aorta and LV catheter 4 French. So this is the first recording I obtained, and it seemed like there is about 40 millimeter of mercury peak-to-peak gradient. So it fits with severe AS. But again, I didn't like the tracing. So we flushed, changed the catheter length, and this is the gradient we obtained here. It is a lot less. Look, we went from 40 to almost 20 peak-to-peak gradient, dramatically less. And now we see, look, the upstroke is sharper here, and we see a dicrotic notch, which we did not see on this recording. So again, dramatic change in management. I mean, if you stick with this recording, you will send this patient for aortic valve replacement. You will call it a truly severe low gradient AS. Whereas here we know it's not truly severe low gradient AS, it's moderate AS, and the valve area, we measured it as 1.2 centimeters square. So it's what we call falsely severe low gradient AS by echo. It's not a truly severe low gradient AS, it's falsely severe echo low gradient AS. Okay, it's echocardiographic mismeasurement. You got that? You understand that case? That's another case I've done also. This is a 67-year-old man. He has severe clinical heart failure, very low EF, and echo read low gradient AS of unclear severity. Okay. So I tried to, we did initially a measurement, and we used 2 transducers. One is a standard transducer, the other one is the assist automatic injector transducer. So we got this recording. Initially, it seemed there is almost no gradient at all. Didn't make sense to me. I thought in this case, the LV is damped. Look, the LV is fairly too smooth. There are no dips and valley in the left ventricle. Okay, let me show you, you know, there are usually some notches, some dips on that left ventricle. So what I did here, I flushed, but nothing changed. So I swapped the transducer. I put transducer 1 on the LV and transducer 2 on the aorta. And look what happens now. The LV is not damped anymore, but the aorta is severely damped. Look, the aorta, which on this tracing had an anacrotic notch and a dicrotic notch, now it's fully damped. So now we go with no gradient And when we swapped the transducer, we went to 40 millimeter of mercury gradient. So you know there is an error. So with the swapping, so again, we swapped at this level. Since we swapped, we got a totally opposite gradient. That means that you have damping problem across the point of swapping, beyond the point of swapping. So across the tubing or the transducer. In this case, the error was across the transducer, across the assist, and the length of the tubing. So we got two manifold type of standard transducer in this case. And whenever you see this, you know that your gradient is somewhere in between. It's between 0 and 40 millimeter of mercury, which is not helpful at all. So anyway, we changed that transducer to and its tubing, and we got this recording. And this time when we swapped, we got the same, almost the same pressure measurement. So we were happy with this. So the peak-to-peak gradient is 25 and cardiac output is 3.9. I want you to be able to do, I will explain to you how to measure valve area in a next talk, but I want you to be able to do quick math. I want you to know the quick equation of valve area. Here, this is the next talk, but this is the quick math of the valve area. You need to know that. Cardiac output divided by square root of mean or peak-to-peak gradient. So you need to be able to do it mentally. So cardiac output divided by square root of this. Very easy. That's the Hackey equation. So 3.9 divided by square root of 25, which is 5. So you know already your valve area in your brain, as you're doing your case, you know already your valve area is about 0.8. It's almost 4 divided by 5. So it's almost 0.8, and it measured 0.75. Okay? So quick mental calculation before you go back and review everything. So it fits kind of with the echo. So we have in this case low gradient AS with a valve area less than 1 in a patient with severely low EF. This is a case where we do dobutamine to assess the severity of ES. And this is what we did here. We gave dobutamine. At one point, we go up to 20 microgram per kilogram per minute. We start 5, then 10, then 15, then 20, 5 minutes each level. If at any point you hit your goal, you're done, you proved it. So we, at 10 mic per kilogram per minute, our gradient went up to over 40, while our aortic valve area remained less than 1, or especially less than 1.2. If your gradient goes up to more than 40, even if your valve area goes up but stays less than 1.2, it is a truly severe AS. So that was a truly severe AS that could have been totally missed had we stopped on the first recording. This is a third type of error. So elaborate mostly on error of zeroing and error in damping. This is a third type of error you can see. So again, this is the same patient. You get LV aortic pressure recording in one instance and in another instance. We did something in this patient that made the pressure look different. It's well damped. Look at that LV. It's well damped. It has a good dip. The aortic pressure, there is an anacrotic notch, diacrotic notch. And here is a hint to you. When you do this recording and you see a nice anacrotic notch, that's a hint to you that maybe there is an error here. Could it be an error in zeroing? Could it be an error in damping? Or could it be that error that I'm going to talk about right now? So that's why analyzing morphology is important, because it's a hint for you to do more, not stop at the shallow assessment of numbers. Okay. So what is the what's the error here? Anybody knows? What's making us have that difference in recording? Anybody? All right. Well, it's fairly simple actually. And what it is in the first recording, so let's say the second recording, the true recording, your LV pressure is deep. We're using an LV catheter and an LV pigtail catheter, multi-hole catheter, okay? So this is your LV catheter. Now imagine that pigtail is not very deep. It's halfway across the aortic valve. some of those side holes will be contaminated by the aortic pressure. So some of the LV will be contaminated by aortic pressure. So it will be mixed LV aortic pressure, which attenuates that gradient, okay? Because you're contaminated by the aorta. You're halfway in the aorta, so you get a halfway gradient in a way. So you should ensure your catheter is deep when you're doing recordings, okay? And that's one of the errors you should seek whenever there is some discrepancy between morphology and severity. Everybody understood that?
Sorry, Dr. Hanna, can I ask you a question?
Yes.
For the first image, it seems like the morphology is pretty good. You said everything looks great. It doesn't look damped. Why would you, when would you suspect, or I guess you already said it, but if I was a beginner looking at that morphology, I would think that it's a good reading and that would kind of move on. But what made we need to?
So that morphology doesn't suggest error in damping. Doesn't suggest error in damping in the catheter or in the fluid-filled system. None of the errors I explained here. I agree with you. So, but it can suggest two things here. There is still an error because you can see there is a nice anacrotic notch. Okay, there is a nice early anacrotic notch suggestive of severe aortic stenosis. So it suggests there is an error. It's not an error in damping. You are correct because the tracings look nice with nice dips and valleys. But it suggests another sort of error. The more common error would be error in zeroing, meaning the two transducers were zeroed not at the same level. So you re-zero your system, both transducers. If that doesn't correct it, then think of that third error. That's your sequence of events. And do under X-ray, look where your catheter is, reposition it. You know, a lot of time you might be stuck in the mitral apparatus. And so half of the catheter is a mitral apparatus, half of it is across the aortic valve, okay? When you have that error, you don't damp the tracing, you just damp the height. It's just that your LV is mixed halfway aorta, halfway LV. You kind of got it. It's just going through the step and recognizing those three types of error. But again, I agree, this is not the second type of error. This is not the damping type of error. Any other question? Yeah. Any other questions? So this is another important idea I want to highlight here. So of course, that type of error will be less likely to happen if you're using a single end hole catheter. But even with an end hole catheter, one error can happen. It's this important idea I want to highlight here. When you have AS, you have most of your obstruction across the aortic valve. But indeed, even in AS, you do have some degree of LVOT obstruction and some degree of LVOT gradient. A paper in the 80s, a physics paper in the 80s, highlighted that actually before the full gradient of AS is actually summation of AS gradient and a little bit of LVOT gradient. It's the same thing you get on echo, the flow acceleration, the aliasing that starts upstream of the valve. So you're starting to have a continuum of pressure gradient that starts across the LVOT and peaks at the aortic valve. So basically, if you put your catheter, even an end hole catheter, across the LVOT rather than the LV body, you're going to underestimate that gradient, okay? Because again, the gradient builds up and peaks at the aortic valve. And that's again the same reason why your LVOT velocity, when you're doing it by echo, you should not put the LVOT cursor too close to the aortic valve, because you'll be catching part of the AS anatomy and part of the flow acceleration that's part of the AS. This is not subaortic LVOT obstruction. This is part of the AS anatomy, the AS flow acceleration, and the continuum of gradient that you build before you reach an obstruction in general, okay? So that's another reason to put your catheter deep in the LV body. I'll skip to two other important ideas here. Atrial fibrillation. I love this topic. Atrial fibrillation complicates everything in cardiology, but it makes also everything so much more interesting. So how to measure gradient in atrial fibrillation? So in atrial fibrillation, unfortunately, I don't have a picture of it. In atrial fibrillation, you will have beat to beat variability of that gradient, okay? So the gradient is this much in one beat. If you get a long RR interval, the gradient will be higher. simply the idea is long RR means long preload and more stroke volume, which causes long stroke volume, larger stroke volume causes higher gradient. Gradient is proportionate to flow by definition using Gorlin equation. So long RR in atrial fibrillation will cause a higher gradient. The common wisdom and the common recommendation in textbooks as well as in the ASE echo guidelines is to average the gradient in atrial fibrillation across 5 to 10 beats. I believe this is incorrect. Actually, the best gradient in aortic stenosis is the highest gradient. So you look at the tracing and you find which gradient, where is the highest gradient? Basically, after the longest RR and the longest gradient and the highest gradient, this is the one you take, okay, the longest RR. And it's typically a long RR that's preceded by a short RR. That's your highest gradient, that's the gradient you should take. And here's the explanation. You need to know in hemodynamics, AFib is a low output state for a couple of reasons. One is, of course, you lose the atrial kick and that creates lower stroke volume, but also irregularity. Irregularity by itself reduces your cardiac output. And atrial fibrillation is a low output state. So even when it's rate controlled. So for that reason, atrial fibrillation is a low output state. So by definition, you want to grab the highest gradient you can get. So definitely get the highest gradient. Don't average down gradient, whether by echo or by cath. And there are some papers in the echo field from Mayo Clinic suggesting that idea, but it's a common sense. AFib is a low output state. I showed this slide in the past. So this is and I want to highlight the importance of irregular rhythm. This is a patient with a regular rhythm, sinus rhythm, let's say, of 90. Actually, let's call it not sinus, AFib with a regularly paced rhythm of 90. This is a patient with AFib and irregular rhythm of 90 and AFib and differently irregular rhythm of a rate of 90. The more irregular you are, the lower your cardiac output is, okay? The more striking the difference between RR, the lower your cardiac output is. And this has been shown in multiple studies, especially when your RR varies between less than 85 to over 120 beats per minute intervals. Okay, simply because your best cardiac output is for RR interval in that range, 85 to 120. What happens if your RR, the too short RR drops your stroke volume in a way that a long RR does not make up for it. Shortening to less than 500 milliseconds, which is 120 beats per minute, dramatically drops your stroke volume, and it's not made up by lengthening it to over 700 milliseconds, okay? I will highlight one more idea, then I will stop. It's the idea of low gradient aortic stenosis with normal EF. So we have somebody with an aortic valve area of 0.9 by echo, mean gradient of 27, and normal EF. What is the next step for this patient? Dobutamine study, exercise, nipride, cath gradient, calcium score of the aortic valve, or aortic valve replacement. Multiple answer here could be correct. The more important answer for me is dobutamine study the right answer? So here's what I want to highlight, especially for the new fellows. In low gradient ES with normal EF, the issue is not contractility. The reason, even when it's true, and I will talk about truly severe AS with low gradient, because half the time, this is not truly severe AS. This is false echo measurement. Half the time, automatically, when you see this on echo, the immediate reflex, half the time it's incorrect. Now, the other half, it is a truly severe AS. Now, even when it's truly severe AS, it's not, the low gradient is not due to impaired contractility, unlike the low EF. The low gradient is due to impaired loading condition. So those patients have thick LV with a small preload, small diastolic filling, small preload, and they also have high afterload, hypertensive disease. Okay, so they have that preload afterload mismatch. So you have low preload, high afterload, and that's what's causing the low stroke volume and the low output. it is not a contractility issue. Actually, dobutamine will make it worse. You give dobutamine to those patients, you shrink diastole, you further reduce their preload. And you could potentially reduce their gradient by giving dobutamine. You can make them hypotensive by giving them dobutamine, because the issue is a small preload, high afterload. It's not improved by dobutamine. So what you need to do in this case, it is not unreasonable to do exercise and nipride. There are two studies that address that, two very nice studies that address that, and show that 3/4 of those patients are truly severe if you do those studies. But what we do nowadays, we just mainly ensure that those measurements are correct, whether by doing cath or by verifying using aortic valve calcium. And once those measurements are correct, we assume it's truly severe AS, as long as it's not echo mismeasurement. And the reason that you get a truly severe low gradient AS, I've highlighted those. The more common thing is hypertensive heart disease, but there are some other overlooked causes. Atrial fibrillation is another cause of low gradient truly severe AS with normal EF. That's why, again, I take the highest gradient in AFib. Another one is amyloidosis. 10 to 15% of low gradient normal EF AS are amyloid heart disease. Another one is mitral valve disease. So when you have on echo low gradient AS with a valve area less than 1 and a gradient less than 40 and especially less than 30 with normal EF, there are those three types. The first type is echo mismeasurement, especially falsely low measurement of the LVOT diameter, especially when you read the echo report and you see LVOT diameter less than 2.1. Overwhelmingly, this is incorrect. So that's one error in measurement, LVOT diameter. And this is unveiled by measuring the dimensionless index. Okay, if it is less than 0.25, it's likely truly severe AS. Over 0.25, unlikely to be truly severe AS, likely mismeasurement. Another echo mismeasurement is what we call pressure recovery phenomena, which exaggerates the gradient and reduces the valve area calculation. So that's why whenever you have this, the first thing is to remeasure you redo your echo measurement, preferably after controlling your blood pressure. And the second step, if you still come up with the same problem, with the same valve area, is to do cath or valve CT calcium scoring. Those are the two techniques we do to confirm that. CT calcium scoring is the easiest. Calcium score of the aortic valve over 2,000 in men and over 1,200 in women confirms severe AS. The second possibility is low gradient true AS with a low flow despite normal EF, defined by a stroke volume index less than 35 millimeter per meter square. And this is this mechanism that I explained here. The third possibility, and actually that is more common than number two, low gradient true AS with actually normal flow. The guidelines are obsessed with that low flow and calculating stroke volume index, which must be less than 35 for AS to be severe. A larger proportion of patients have normal flow rather than low flow. And why? In those cases, you have truly severe AS with low gradient, yet a normal flow. The low gradient in this case is easily explained by the guideline cutoff misalignment, meaning we call it severe AS when the valve area is 1 and the mean gradient is 40. But if you plug in the Hackey equation, valve area cardiac output divided by square root of pressure gradient, flip it around, pressure gradient equal cardiac output square divided by valve area square. So under normal flow condition, 5.5 liter per minute cardiac output and a valve area of 1, well, square 5.5, you'll end up with something in the 27 to 30 millimeter of mercury gradient. So under normal flow condition, you have misalignment of guidelines cutoff. Valve area of 1 may not correspond to a gradient of 40. It's more valve area of 0.8 that correspond to a gradient of 40. That said, it's appropriate. The guidelines, echo guidelines are appropriate because you want to pick a gradient cutoff that is very specific. But keep in mind, there is a caveat. And once your valve area is 1, several prognostic studies show that under normal flow condition, a valve area of 1 with a low gradient, still prognosis is improved by valve replacement. Okay. So I hope you understood those 3 points. This is again very different from low gradient AS with low EF, where the issue is contractility and where dobutamine would work. So did everybody understand the three mechanisms of low gradient AS with normal EF? And what are the next steps in general? One question is that if you have low gradient AS with low EF, would you prefer dobutamine study by echo or invasive assessment? No, you should, the first step should definitely be dobutamine assessment with echo. So you do it with echo, you redo your measurement, gradient and aortic valve area with echo every step of the way. So you give dobutamine 5. I had a case earlier, but you give dobutamine 5, then 10, etc., until you see whether you reach those targets. So it is echo for sure. You know, there are cases, I didn't explain it, but, you know, by dobutamine echo in low EF, the goal is to achieve a mean gradient over 40. No, I don't have it here. A mean gradient over 40 and an aortic valve, while the aortic valve area remains less than 1. That's the goal. Now, you will have cases that are in a gray zone. For example, you'll have a patient whose gradient increases to over 40, but the valve area goes up above 1. Again, based on some data from Mayo Clinic, if it goes up above 1, but only a little bit, it stays less than 1.2, then we're good. It is truly severe AS. Conversely, and not uncommonly, you will have cases where the gradient will go up, but it will not go up enough. It will remain in the 30s while the valve area remains less than 1. Most often those cases, when the gradient goes up over 30 and the valve area remains less than 1, even if you're not going up in the gradient beyond 40, you are truly severe AS.